Good morning, ladies and gentlemen. It's indeed a privilege to introduce our distinguished speaker today. She has been a pioneer of organ transplant in India, and with her dedicated work, she has given hopes to many and indeed has saved the lives of countless. So please join me in welcoming Mr. Trivedi here. Please.
Yes. Thank you, Mr. Chairman, and good morning to all. To be lighter side, I thought the disease donor transplant program is already deceased in India, but I have to thank the organizers for thinking it's an important topic and inviting over me. Now, what I'm talking is my 30-year experience in this field and how it developed, where are we stuck, and what are we supposed to do. Now, before 1994, everybody knows that living donor kidney transplantation was the only means which was known as a transplantation. There were no defined legal work that time, no framework for anything. Every nursing home probably, especially in the boundaries, were doing lot of transplants, getting foreign recipients and local donors. And probably there was coercion and malpractices were quite a lot. The vision that time, when this law came, I thought, this is a new thing in the science. We must learn, we must teach our students, and probably we will be increasing the donor pool. This was 94, 95, 96, where kidney transplantation was the only vision that we had. And probably somewhere illegal activities can come down. Both, this is not our main aim. So with the multiple attempts to identify brain death, maintain the donors, counsel the families, and the most difficult task, which is then and which is today also, to convincing the hospital authorities and colleagues regarding the scientific way of disease donor transplantation. It was my 13th attempt. On 27th of March 1997, I could do a protocolized disease donor successful transplantation in a medical college, and thus I thought I opened up the gate for further progress. The progress of transplant science as science, from 2000 till 2004, it was kidney-only transplantation. 2004 to 2008, probably the DDLT gained the momentum in the entry of the transplant team, because many of the transplant teams went abroad, learned, and they came and they wanted, and corporate hospitals took the chance. 2012 onwards, same thing happened to the heart. 2015 was a history creation with the successful hand transplantation in the Cochin. But non-availability of the donor was a challenge then and challenge today also. Now, transplant as a program had to be developed, which started in Maharashtra by 1999, where government started with the GR, government-involved program, which made our life much better. We had 4 ZTCCs which could oversee the transplantation. It was a regulated PPP model, but the most importance, which we are lacking today also, is involvement of every hospital and regular meeting of every hospital chiefs in every second month, and discussing how to go ahead and making the policies. Now, other states also, with the help of ZTCC, started by 2005 till 2014, 2017, 18, even Odisha and West Bengal also took almost that attempt. This is the time, it runs very fast. Okay. Important milestone before Noto. Noto started in 2014. Before that, there were a lot of attempts made by a lot of people in deliberation at Delhi, Mumbai, Kolkata, etc. It was an NGO driven program, no government involvement till then. And 2008, probably we presented the amendments which were accepted by the Rajya Sabha, and we also presented to the WHO, which said that we require a central organizing committee. The leap of transplantation occurred after 2015 because multi-organ transplantation came into the picture, NATO came into the picture, interstate transport became easy, police sensitization occurred, and the green corridor sign occurred. Till the COVID, and after the COVID, the graph is down. I think it's a time to introspect in India that 2024 TOHA is 30-year-old, and NATO will be 10-year-old. Across the country, there is an extreme amount of public awareness driven by government as well as all the NGOs. But has it reflected on the number of disease donor organ donation? Have the numbers of living donation have come down, or any of the waiting list has burdened, have less burdened? So what we gained in these years, yes, initially law was only in Maharashtra, Goa, Himachal Pradesh. Other two states never probably started yet. I do not know, may have just started. Maharashtra went ahead of everybody. Surgical standards are, technique are standard, probably laparoscopy for the kidney, probably robotic for the kidney may have come. But I just want to know the cost, the skill, and the centers where it is available so that you go ahead with the robotic. Liver, yes, liver split donor has started, so many recipients may get benefit. And heart, lung, ECMO becomes an armamentarium to maintain the recipient for longer time till the many things happen. Preservative fluid was an extreme amount of challenge once upon a time. Today, with the availability of HTK, we are not bothered much about it. Lymphocyte cross-match also. Many more advanced tests are available. In fact, Karnataka is doing the matching with the HLA matching donor allocation. Allocation methods are standard. These were the challenges once upon a time. Have we gained any ground on those challenges? Yes. Many of the states have adopted law, but how many are practicing, I would not know. Surgical techniques are standardized, and preservative fluids are standardized, lymphocyte is standardized, and all are standardized. Now, organ transplantation, India is second next to USA regarding the number of the transplantation. But disease organ donation, we have not yet crossed 1 per million. My talking prior to me, somebody said, transplantation is a science, and equally organ donation is also science which we have to develop, which we have not developed. So it is time that we have to analyze, understand, and correct the system. Where are we failing? Do you really feel there are no donors? No, I don't agree. It is a failure of a system to transform the potential donors into actual donors. The cause, the biggest cause I would say, which I have marked in the red, lack of leadership, reluctance to own up the program, so nobody takes the responsibility. As a surgeon, I say, see, physicians are not giving the recipient. Physicians say, see, the intensivists are not giving the organs. Intensivists say, we don't have the infrastructure. The hospital chief feels, hey, I don't want to get into all that, so I'm not going to get in, because nobody is accountable. We have undertrained, untrained staff. Failure to detect BST is the main cause, and maintaining the donor is the biggest hurdle. Reluctance to approach the family, and total apathy and unaccountability of all the hospitals. As you know, there are 4 pillars. You have to have a government, you have to have medical institution, domain expert, and the society. The strong pillar should be medical institutions and the professionals. The government and society are just the supporting walls, but we have made them into center point, because that is easy, that you see this way or you see that way without knowing what is to be done. As all you know, the TOHA was promulgated in 1994, amendments TOTA was 2011. Essential point in TOTA was recognizing non-transplant organ retrieval centers. I have my doubt across India how many have been okay. There is an exception probably, Ahmedabad Civil Hospital, which they have done voluntarily. Beyond that, I do not know anywhere. The brainstem death is okay. The third point, mandatory inquiry informing the relatives of BSD by the intensivist regarding the option of organ donation. Isn't it so ambiguous? Which intensivist voluntarily will go कि भाई this fellow is brain dead, so अभी organ देने का आप think करो. Does he have time? If you think you don't have time, they also do not have the time. So I think it is still very ambiguity, and that's why it is not implemented anywhere. Employing the transplant coordinator, which was made compulsory. Every hospital have the coordinator, but we have to ask, the coordinators are used for what? Most of the time they are used for the living donation or as a front desk clerks, nothing beyond that. The priorities, as somebody earlier to me also said, I was very happy it is not only me talking like this. The donor requires much more attention than the transplantation. All of you feel great by doing, including me. When I do the transplant, when urine comes, I am on the top of the world. But if you want to do the organ transplantation, you require the organs, and that is also a science. The disease donation is, in last 3 decades, have gone up from just 0.08 to just 0.8. Disease donor program, wrong priorities where India has failed. DD program should be a scientific hospital program. I am very clear on this, you know. In last 30 years, the authorities, the hospitals, the reluctant medical professionals have successfully converted the entire program into the social program. The society remains permanent punching bag to tell that our society does not accept, our culture does not accept. There are enough studies are available that though probably 80% of the population may not know, that is especially in the north, South, Maharashtra, Gujarat, I think the society is enough understanding. So, in spite of that, if you approach them and explain them, more than 95% have no objection of donation. In spite of the gender, poverty, education, they have no problem in donation. We have paid total attention on pledge collection and all that, I mean, skits, street plays, etc. We are also telling that we want to introduce this subject in the 9th standard secondary school. Is that children, aren't you burdening the child for unwanted information? And second thing, is that child is legal heir to give the signature in case anything happens? So I feel it is waste of time, energy, and we are leaving the main track and going to this side. The need of the hour is main problem for the robust transplantation is the organ shortage. We must have a supra-hospital agency, should be autonomous, working under public health department on the basis of scientific analysis of these many years rather than perception. मुझे ये अच्छा लगता है, so I am doing this. This is how we run. So I think that should not be done. We require effective decentralization and getting involved with the local network. Entire South India is doing very well. Maharashtra is doing very robust organ transplantation. So it has to be going and finding out what is going on there and what is wrong with us. And then we have to implement. Training the target group. We are training coordinators, surgeons for retrieval on the cadaver, etc. By the time they are going to apply, probably they have forgotten the whole thing. And coordinators, which coordinators? Our coordinators are non-medico. So they have held on the program for last 30 years. But they have entry only outside the ICU. They cannot enter the ICU. So we'll have to see whether we are targeting or we are training whom we are training. And networking with the hospitals are most important because involvement of the hospital was the success in Maharashtra. Impartial system should be there. Maybe we can use AI in future. The professionals, being a surgeon, I'm telling you, they are totally bored. Losing interest in DD program because long hours of duty, more than 20, 24 hours, you have to work without provision of any remuneration or appreciation. fractured doctor-patient relationship in the society, hanging CPA on your head, and workplace violence. These are all the factors also where people are not wanting to go for the DD The roadmap for the government must introduce all NTORC, all medical colleges must be made NTORC. There are about 1.6 people with the road traffic accident. Most of them, they come to the public hospital. They don't go to the Bridge Candy, Jaslok or Apollo or etc. because nobody pays for them. So hospitals must take donor action as their prime. The hospital chief or administration must be held responsible for not doing this duty to the social, public, as well as to the students. And coordinators must be qualified, intensivists, anesthetists, etc., so who have an entry to the ICU. Now, NGOs are working, let them work. I have nothing, they are supposed to be the part of the society. But I think they should, it is their duty to make the society accept the brain death and organ donation and impartiality or transparency of the program, not beyond that. Same way, media, I would request, should not get into yellow journalism and TRP rate increasing. So, in conclusion, disease donor organ transplantation is boon. Everybody knows medical institutions, doctors, government, society must work in unison and must be concentrated and focused approach rather than if you want to put a nail in the wall, you have to hit on the head of the nail, not all around the nail and say, hoping that nail will go into the wall. And must be a corporate activity so that no one reaches there unless everybody reaches. We need to stop reinventing the wheel, which is given up in most of the foreign countries at every stage, and try to work in unison towards the successful scientific medical program rather than social program. Thank you.
Thank you, madam, for your nice presentation and thoughts how we can proceed, or we can improve the disease donor program throughout the country. Some of the states have done very well, and I remember the initial period, only the Tamil Nadu people were doing the lot of kidney transplantation. I got a kidney from, Vellore, which was rejected because of so many reasons, high age and etc. So the kidney was flown to Hyderabad and transplanted. That was way back in 2011. But after that, the Telangana Jimandan came, and there is a big push, and now Telangana is one of the top performer in the disease donor transplantation. Now we are doing more organ transplantation, disease donor than Tamil Nadu. So if the effort is taken, which has, of course, lots of issues, we can increase it, and there are states which are increasing very rapidly. I appreciate your concern about the donor management, which we face regularly, because the donor management is never at the hand of nephrologist, and many times we see the donor quality get deteriorated after the donor kidney quality get deteriorated after admission. And when we question the critical care people, we don't get away, we don't get the right answer, and we are not much able to improve the scenario. So as a rule, the nephrologists are not supposed to be there in the management of the donor unless they are given a cross consultation. But we need to sort of have that angle also in future.
Sir, can I tell you? That is what I am surging. Neither nephrologist, nor urologist, not hepatologist, not gastroenterologist should be in charge of the program. The program has to be handed over to the intensive care, and the hospital chief should be knowing that intensive care person is doing. Because there is tomorrow, God forbid, there is a case against any nephrologist who is looking after, because government had told you to look after the program. And if there is a court case, government doesn't come to protect you, and government
that is we have to maintain the rule, but I'm saying that critical care needs to be educated.
What I'm telling, if you think Tamil Nadu, Maharashtra, Telangana are doing excellent, we have to follow points from there rather than reinventing in every state.
True.
So it doesn't take 30 years to a child to become, remove his infantile.
I think
Everywhere we
gentlemen-
say it is infantile. I want to ask, till 30
Yes,
years,
yes,
anybody
yes.
can be infantile?
Yeah, I think there are a lot of questions. It's open for the discussion. Madam, please.
Yeah, it's not a question to Madam. The way Madam deliberated shows her passion and dedication for the program for last 30 years. I think Madam was involved from the very beginning. But where the nephrologist's stake lies, what Madam was talking of, that the program will be owned by the intensivists and the administration. Yes, they will remain an important part, but still now I feel that nephrologist has a different stake in this program, because every day morning the nephrologist takes the dialysis round where he or she sees the unsatisfied face, which drives him or her to this, but not the intensivists. So still now the intensivists group, they are not experiencing the problem firsthand, and we still need to sensitize the intensivist society, and we have to keep on doing this duty for few more years. We have to own this program somewhere, that we need it for our patients.
No, I agree. Intensive, that's what I'm telling you. Let us have a targeted training. Intensivists are also part. If you give them the responsibility
Madam,
of
let us hear the other questions and you can answer together.
I have a
Please.
couple of comments, no questions. It's an excellent presentation. We are talking about how to improve the number of organ donation and how to preserve the quality. So a couple of suggestions, or maybe my own thought process. Number one is that how to improve the number of organs. And wherever you see in the country, the number of organs have gone up only where the NGOs are active. I am yet to see any state where the government-run organ donation program is active. I am from Gujarat, I am from Surat, and our city is one of the highest organ
Telangana
donors.
has it. Telangana has it.
Yeah, so I mean,
No,
one of
Gujarat
the-
is highest because involvement of the civil hospital. That's what I'm telling you.
yes.
NGOs sensitize the society, but the hospitals have to take up the cost.
Yeah, I'm coming to that only. So that because the NGOs would be the neutral party, so their acceptance to the society would be much more. And second is that number of how to improve the quality of organs, because when it comes for a nephrologist, it comes the quality of kidney, and the longer the ischemia time, the kidney is poor at performing.
I'm not gone into details.
So, meaning what I mean to say is, again,
Let us take some more questions. Yes,
Yeah, sure.
please. More participation is better.
Not any question, just a comment. Actually, I am Dr. Kole. I am the in charge of intensive care unit of 𝐕𝐚𝐭𝐬𝐚 Clinic, Kolkata. In fact, the first diseased organ transplantation, when it was done in eastern zone of India, I took the initiative. And what I want to say that in our society, particularly during the national conference, we are regularly having this diseased organ transplantation workshop specifically, and we are organizing meeting on how to maintain donors, and this is our regular scenario. I think that in future, that whether our Indian Society of Critical Care Medicine and ISOT can work together in future. I think that the things will be moved.
That's a great comment and suggestion. Next, some more questions.
I'm Colonel M.N. Mishra from Pathfind Laboratories. I just have one comment. I have a passion for disease donor transplant. What I've found is that most of the recipients are not worked up from before, and the donors are not typed for HLA typing. Now, with the recent advances, it is possible to do the HLA typing within a period of 2 hours after the receipt of sample. And I have interacted with nephrologists in many places. If ISOT can influence, I'll ask them to tell the government that this is a must. Whatever the resources are, it's a very valuable resource. And we need to have longevity of the organ. So you need to do a pre-transplant workup regularly by way of immunological monitoring. Very simple tests, PRA screen and single antigen bead assay, if it's a sensitized case. And recipient HLA typing and disease donor HLA typing. Then tomorrow if the recipient is young, he or she gets a second transplant, then you know what are the antibodies which are present in the recipient so that you'll avoid a repeat transplant if possible. This is my comment.
I think Karnataka is already doing HLA matching before allocation. That's the only state which has started HLA allocation. According to the HLA allocation, I agree HLA should be done, provided you get the organs, doctor. I am telling, increase the organs first and do what you feel like.
I think we have 3 minutes. Professor Chakku, please.
Just a comment actually on non-transplanting hospitals as organ donors. Last month there was a very interesting meeting at IIM Bangalore, which was in collaboration with Noto, IIM Bangalore, NIMHANS and Mohan Foundation. And there were a lot of transplant coordinators, and for 2 days they were discussing this possibility of having non-transplanting hospital as for organ retrieval. So I think the first step has been made. How it will come to fruition, we just have to wait and see.
One last comment, please. What steps are being taken by the Health Ministry? What steps are being taken up by the Health Ministry regarding augmenting our disease donor transplantation program?
See, I don't know what Health Ministry does. What we advise them, they come out. Now, there is a advisory probably introducing organ donation in 9th standard of the secondary school, which disturbed me quite a lot. And they say that we will collect the pledges, and we have collected X lakhs of pledges. Now, you know what is the Abadi of India? 140 crores. By the time you collect all that, probably the transplant process will be going and 2-3 generations of recipients will be disappearing. So that is a side by side, I suppose. What we require is teaching in the undergraduate MBBS course regarding the brain death and the nitty-gritty of, not much, so that those students sit in the ICU for monitoring the patients will recognize the brain death goes unrecognized. So we'll get the recognition.
Yeah. No, I was referring to the fact that there has been some steps in altering some of the laws and the requirements for deceased donors. For example, the bar for recipient age has been reduced, has been taken away. The domicile certification is no longer required. And also, what we say, some relaxation in terminal life care, or in other words, passive euthanasia. And of course, training of personnel. I believe Noto also has initiated some training program for organ transplantation program and training of transplant coordinators. I believe this is all happening.
So I know, but all these are just I'm asking you also, if there is no detection of the brain death in ICU, whatever you do, how will you increase?
Agreed. Really
so
agreed
you have to concentrate first, train the organ donation process first, and then do whatever reforms you want, you can do it. Unless somebody detects brain death and somebody maintains that organ donor, I don't think all of we are talking is theoretical, sir. It is no practicability.
Absolutely. Thank you so for an excellent presentation, a very, very, very active participation from the audience, and I believe we can declare the session closed.
We would like to present a small token of appreciation and a memento, requesting Dr. George Abraham, who is the President ISOT, to do the honors.